Good morning, ladies and gentlemen. Welcome to week 3, lecture 4 of this course on physical medicine and rehabilitation in sports. Today, we will be dealing with an important topic called clinical and functional testing in sports injuries. I am Colonel Dr. Anup Krishnan. I am a sports and exercise medicine physician, and I will be taking you through this topic. I'll be covering this topic as per the following outline: introduction, objectives, clinical examination. We'll discuss some functional tests, some special tests, some advances in the field, and as usual, we'll conclude with a take home message. Clinical and functional testing plays a critical role in assessment of sports injuries. Where is the injury? How did it happen? How severe is the injury? What is the definition of the injury? All these can be picked up by clinical and functional testing. It helps to determine injury severity, how is the progression of the rehabilitation progress, and the return to play readiness. It integrates physical examination, movement analysis, and objective performance tests. What are the objectives of clinical and functional testing? Identification of deficits in strength, mobility, and neuromuscular control. Once you identify these deficits, you can address them. Provides baseline measures for planning of rehabilitation. Assessment of functional capacity and sport specific performance. It also guides safe return to play decisions. Let's talk about the overview of the clinical examination. We start with the history taking. What is the mechanism of the injury? Whether it was an acute injury, whether it is an overuse injury, what is the type of the trauma, what is the direction of the trauma. All these are very important. We ask for symptoms, we ask for pain levels, and we ask for history of any previous injuries. We also take a look at the training load on the athlete and any biomechanical assessments which have been made available. Observation and palpation. We look for any swelling, bruising, asymmetry, and muscle wasting. We look for any point tenderness over the structures. We do special tests for joint stability, ligament integrity, and for neurological function. Let's start with the range of motion assessment. Always do an active range of motion assessment first, because if you do a passive range of motion assessment and you push the joint beyond what the patient can safely tolerate, you will injure the joint further. So, always active, which the patient does himself, and then passive, which the examiner does himself. Use a goniometer for objective measurement. And please do a functional movement comparison with the uninjured side. Strength testing. Generally, what is done first is called manual muscle testing for gross strength assessment. Each muscle group is tested and graded from 0 to 5. If you feel that manual muscle testing is not accurate, you may go in for something called handheld dynamometry for measuring precise muscle force measurements. However, for muscle strength testing, isokinetic dynamometry is the gold standard, and it is to be used for assessment of dynamic muscle function if you want accurate results and if you're doing any research. Neurological testing. You do a sensory evaluation for light, touch, pinprick, and vibration. You do a motor strength grading using manual muscle testing. You assess the reflexes such as patellar, Achilles, etc. And you do functional tests for nerve entrapments like Tinel sign, Fallon's test, etc. If we come to the joints, we have to test all the ligaments for stability. In the knee, the test for ACL ligament stability is called anterior dart test or Lachman's test. You also do a valgus and a varus stress test to assess the MCL and the LCL. In the ankle, you do an anterior draw test to assess the ATFL integrity, and you do a talar tilt test to assess the CFL integrity. In the shoulder, you do an apprehension and relocation test. Basically, you're trying to look for how easy it is to dislocate the shoulder. And if the patient shows apprehension in any particular movement, you know that the apprehension test is positive. In any ligament stability test, what you're trying to do is stress the ligament and see whether you can elicitate ligament laxity. Meniscal and cartilage tests. There is something called a McMurray test, which evaluates meniscus tears. You can also do an Apley's compression test for assessment of meniscal tears. And Thessali test is a functional weight bearing assessment of the meniscus, which can be done quickly. Tendon and muscle tests. Any tendon can be put under load in the direction of the load bearing and can be tested. If the athlete is unable to perform that activity, you can conclude that there is a tendon rupture. So, Thompson test for Achilles tendon, Speeds test for biceps tendon, and empty can test for supraspinatus tendon. You also do something called a functional movement screening or FMS, which identifies deficiencies in mobility, stability, and coordination. This test includes a deep squat, hurdle step, inline lunge, active straight leg raise, trunk stability push-up, and a rotary stability test. There is an FMS kit which is available nowadays, and you can safely do all these tests using the kit. And FMS is now being used in injury prevention and for performance enhancement. Balance and proprioception training. Balance and proprioception testing can be done using single leg balance test, which assesses postural control. You can also do something called a Y balance test, which evaluates the asymmetry in the lower limb. There are several balance and stability testing systems which are available, which objectively tests balance and dynamic stability and gives you a proper analysis report. Core stability testing. We are used to doing planks, so we do something called a plank endurance test. We are used to doing side bridges, we do something called side bridge endurance test. There are exercises which are called dead bug and bird dog exercises, which are used for dynamic core stability assessment. You can also use these for training of the athlete. Agility and speed testing. The T test can be used for multi-directional agility. You can do various shuttle runs and shuttle tests, such as the 5-10-5 shuttle run for cutting speed. You may use various sprint tests, 30 meter, 40 meter, 60 meter, 100 meter, for acceleration evaluation. These sprint tests use timing gates. Jump and power assessments. You can use vertical jump tests using force plates or VECTEC system. You can use broad jump test for lower limb power analysis. You can use reactive strength index for plyometric efficiency. Please note, ladies and gentlemen, you do not need very sophisticated instruments for doing assessments. If you search for a paper called Standing Broad Jump versus Wingate Test Analysis for Explosive Lower Limb Power, you will find some very familiar authors, and you will realize that you can do very commonly available field tests, and you really do not need, if you cannot afford, fancy laboratory tests. Endurance testing, the famous yo-yo intermittent recovery test, which evaluates aerobic fitness. You can also use beep test, which is a multi-stage fitness test for measurement of VO2 max indirectly. And you can do treadmill tests in the laboratory for assessment of aerobic capacity. In the laboratory, a breath by breath metabolic analyzer using an incremental treadmill or cycle ergometer protocol is the gold standard for assessment of VO2 max. You may need to do sport specific functional tests for cutting and pivoting drills for ACL injury evaluation. You may need to do throwing mechanics tests for shoulder injury risk assessment. And you may also need to do landing mechanics analysis for injury prevention. These may use two-dimensional motion analysis or three-dimensional motion analysis. Return to play criteria. Pain-free, full range of motion and strength comparable to the uninjured side. Functional test completed as per pre-injury levels. The athlete should have full confidence in sport-specific movements, and objective tests such as isokinetic strength analysis should be more than 90% of the uninjured side. Concussion assessments are usually done by something called SCAT-6, called Sports Concussion Assessment Tool. In boxing and sports where head injury is common, we use King David test for visual tracking. Please note, SCAT-6 and KD test should be done prior to the event as a baseline analysis, so that if the athlete is injured during the event, you have a baseline to compare yourself with. You may use balance error scoring systems for postural stability evaluations. Fatigue and recovery can be tested by something called heart rate variability, which monitors the autonomic nervous system and allows for early monitoring of fatigue and stress upon the individual. You may do lactate threshold testing for endurance assessment. You may do sleep tracking, and you may use wellness questionnaires. These should be done regularly for all athletes who are undergoing a training program. Wearables. Again, GPS and accelerometers are used for load monitoring. Force plates can be used for landing and jump assessments. EMG sensors can be used for real-time muscle activation tracking, which these technology basically allows you to monitor the athlete while he is doing his training or competition. Psychological assessment. You can give questionnaires such as fear avoidance belief questionnaire, confidence scales in return to sport decisions, and you can have depression and anxiety screening tools. You can use these questionnaires and tools to assess, to monitor, and to certify return to sport. There are some errors in clinical testing. Basically, there is a lack of standardization in manual assessments because of inter-observer bias. If I do the test, if somebody else does the test, there may be inter-observer bias in the results. There may be inconsistencies in test retest reliability, which means if I'm doing the test today and I'm testing the individual after 2 days or 3 days, there may be test intertest reliability issues. Advances in functional testing. Motion capture technology has been used nowadays for detailed biomechanics. Older technology uses the markers, and the newer technology is markerless. Artificial intelligence is used to analyze movement analysis for early injury detection. And for rehabilitation, you have a lot of VR based rehabilitation tools which help to shorten the rehabilitation period. There are a lot of limitations and challenges for this. Cost and accessibility of advanced equipment is very, very common. There is a variability in interpretation of the test results. And there is a need for individualized test selection based upon the sport and the athlete. Take home message: clinical and functional testing is essential in injury management. Objective measures improve rehabilitation monitoring and return to play decisions. If you integrate technology, it enhances accuracy and efficiency in sports medicine. These are the references which I have used to prepare this lecture. I strongly urge you, ladies and gentlemen, to go through them. Thank you for your patient listening. Thank you and Jai Hind.